Hello everyone. Let us now discuss one of the lengthiest but also the most important topic in neonatology, that is neonatal jaundice. There is so much of information in neonatal jaundice that almost a mini book can be written upon that. But don't worry, I am not going to overwhelm you with information. We'll be doing it in an easy to remember format, focusing on the key concepts. Bit of facts will be put in, and we'll also be discussing the related MCQs in this entire module itself. So let us begin neonatal jaundice. Many of you might have seen that children are born and in the first week of life, sometimes in second week, they tend to develop jaundice. If you have attended your neonatology postings, you would see that there are certain children who are receiving blue-green light, the so-called phototherapy, which indicates that neonatal jaundice is fairly common. The first thing that you need to know is the key points regarding neonatal jaundice. Neonatal jaundice is considered to be one of the most common morbidity. It is the most common morbidity in the first week of life. Two fact-based things can be asked in MCQs. One, 60% of all term neonates and 80% of all preterm neonates, they develop neonatal jaundice in the first week of life. So that is why it is considered to be one of the most common morbidity. So obviously the question arises, what exactly is clinical jaundice? Clinically visible jaundice in newborns is said to be there when total serum bilirubin, henceforth we'll be writing it as TSB, when total serum bilirubin exceeds 5 mg per deciliter. This is your Viva question as well as your MCQ question. What is the cutoff after which clinical jaundice appears in skin and mucous membrane? If you remember, in adults, when serum bilirubin exceeds 2 mg per deciliter, then it appears as clinical jaundice. Whereas in newborn, when it exceeds 5 mg per deciliter, then only we call it as clinically visible jaundice. And that is what we call as NNJ, that is neonatal jaundice. Broadly speaking, there are two types of neonatal jaundice. You can have physiological variety, which is very common. In fact, 90% cases of jaundice which occur are physiological. It is a very benign disorder. And second are pathological jaundice, which comprises only about 8 to 10% cases, but carries severe lifelong morbidity and can even cause death of the child. And this is jaundice which always requires therapy. So these are the two types of jaundice. The first thing in jaundice we need to understand is what is physiological jaundice, because that is the common variety. Talking about physiological jaundice, the name itself is saying it occurs due to normal physiology of the child. So physiological jaundice is very common. Every second or third child will have some degree of physiological jaundice, but it is always benign, self-limited, does not require therapy. Unfortunately, there is no standard definition for physiological jaundice, but there are certain patterns or rules. So you can remember that there is a pattern of physiological jaundice. If this pattern is fulfilled, we say clinically that this is physiological jaundice. This jaundice has onset between 24 to 72 hours of life. In bracket you can write, it never appears in first 24 hours of life. This is your MCQ. First 24 hours of life, that is day 1 pe, physiological jaundice is never seen. If a child is found to have jaundice on day 1, say question says a child is having visible jaundice at 18 hours of life, can it be physiological? The answer is no. It can never be physiological, because physiological will have onset between 24 to 72 hours. It may immediately be visible in this period, or it may slowly become visible. That depends upon how careful, how meticulous the parents are. After onset, we find that if you do investigation, it is always of unconjugated variety. You know that jaundice or hyperbilirubinemia can be conjugated and unconjugated. This is always unconjugated. Third thing, there is no CNS involvement. Normally, we know that if unconjugated jaundice is very high, it is lipophilic and can cross blood-brain barrier. But physiological jaundice is due to normal physiology and body's own defense mechanisms, the body's own tolerance of this jaundice is very good. And so, CNS abnormalities or CNS damage due to this jaundice is virtually never seen. There is no palm and sole involvement. Please understand, when jaundice first appears, it first appears in head and neck, and then as bilirubin increases, it goes on deepening and moves from central part to periphery. It shows a cephalocaudal distribution and proximal to distal distribution. So in the end, when jaundice is very high, when bilirubin is very high, palms and soles will be involved. Physiological jaundice is never so high that palms and soles get affected. The fifth feature, earlier they used to say that up to 10, up to 12, up to 15 is the cutoff for physiological jaundice. However, the latest textbooks do not take an absolute number for total serum bilirubin. They simply say that this jaundice is self-limited. Self-limited means there is no therapy needed in this and tends to resolve within 2 to 3 weeks, within 2 weeks in term and 3 weeks in preterm, as we shall see later. So this is the pattern for physiological jaundice. Any child who's having jaundice, you will get questions based upon this. They will make you a case. If it is fulfilling all these features, you will think of physiological jaundice as the answer. They will ask what next needs to be done. The answer is only observation and reassurance. Nothing else needs to be done. Now, obvious question arises, why jaundice occurs in neonates physiologically? Physiological jaundice, why does it happen? The answer lies somewhere in physiology and biochemistry. If you remember the biochemistry bilirubin cycle, I'm not going to bore you with that. I'll just write the major steps of that. You know that RBCs have a lifespan of, what is the RBC lifespan? In adults, it is 120 days. Right? Newborns, it is less. We'll come to that. Once RBCs are degraded, their lifespan is over, they reach the reticuloendothelial system. And heme from that is released. The globin part is utilized for amino acids are recycled. This heme is acted upon by the enzyme known as heme oxygenase, forming biliverdin. Then biliverdin reductase enzyme acts here, producing bilirubin. This bilirubin, which is freshly formed in reticuloendothelial system, is unconjugated. It is not bind to anything and it is considered to be lipophilic, lipid soluble. It is not water soluble, it is lipid soluble. Anything which is lipid soluble is dangerous. So what body does is, this bilirubin is transferred by albumin. Albumin binds it, right? It is transferred by albumin to the liver. In liver, this unconjugated bilirubin is converted into conjugated bilirubin, which is water soluble or polar or hydrophilic, by the enzyme called as UDPGT, uridyl diphosphoglucuronil transferase. This conjugated bilirubin is secreted into bile, out of which 2/3 is excreted as stercobilin and 1/3 is reabsorbed as due to enterohepatic circulation. This is how, and this reabsorption again produces unconjugated bilirubin. It adds to the cycle. This is the normal bilirubin cycle which you know. Now, question arises, why will newborn have jaundice in the first few weeks of life? The answer is very simple. It is multifactorial. I'll summarize them. First, understand. RBC lifespan in newborn is less, almost 1/3. So, RBC degradation will be less, right? Secondly, the conjugating ability, the RBC level, HB level is also very high. So, net result kya hoga? More bilirubin will be formed. Simultaneously, the conjugating ability of liver, this UDPGT enzyme is not very active. It is not very mature in a child who in the first week. So what is happening? More unconjugated bilirubin coming from the back, less of it getting converted into conjugated. So there will be accumulation of unconjugated bilirubin. That is called as physiological jaundice. So you can summarize what are the reasons for jaundice to occur in physiologically in the first week. The first reason is increased production of, so the reasons are increased production of unconjugated bilirubin. This occurs due to more RBC and more HB levels in the newborn. Second reason, they have a short RBC lifespan. And the third reason, although it is a minor reason, but some books say ineffective erythropoiesis can also occur in newborns. The second reason is decreased UDPGT activity in liver in the first week. It tends to improve with age. And the third reason, which is a minor reason, is increased enterohepatic circulation. So these are the reasons why jaundice occurs in preterm neonates. Please remember, and if you want to make your own handwritten notes, please add them there. And fact-based questions. As I said, we'll be conceptually understanding, but also remembering the fact-based things. What is the RBC lifespan in newborns? MCQ on this has already been asked. In case of term neonates, the RBC lifespan is 60 to 90 days, whereas in preterm neonates, it is as low as 30 to 50 days. The values are taken from standard book called as Avery's Neonatology. So any other value is not valid. This is the value that you are supposed to remember. So this finishes our discussion, the conceptual reason for jaundice to occur in physiological jaundice. Now, what is pathological jaundice? We'll not be talking about physiological anymore because it is the pathological jaundice which is a major problem for us. Any jaundice which does not fulfill the feature of physiological is called as pathological jaundice. And so we have a set of criteria. There are 7 criteria to define pathological jaundice. Any one is fulfilled, we call it as pathological. So all 7 have to be remembered. The first criteria is any visible jaundice in the first 24 hours of life. Even if nothing else is there, still you will call it as pathological, right? Or if there is rapid rise in serum bilirubin. When do you call it as rapid rise? More than 0.2 milligram per deciliter per hour or more than 5 milligram per deciliter in 24 hours. So due to some reason you are doing serial monitoring and you find that jaundice is rising by this rate, then also it is called as pathological jaundice. Third feature is prolongation of jaundice or persistent jaundice beyond 2 weeks in case of term babies and beyond 3 weeks in case of preterm babies. We will call it as pathological jaundice. Fourth, any conjugated hyperbilirubinemia in newborn is called as pathological jaundice because physiological will always be unconjugated. Any conjugated there has to be a disease, there has to be a reason for that. Fifth, any neonatal jaundice where you cannot find any abnormality, but TSB is high, where TSB is high enough to require therapy. So any jaundice which needs therapy by definition becomes pathological jaundice. Once a student called me up. His niece had been born and he said, "Sir, my niece has been put on phototherapy. Every test is fine. Sir, what is it physiological jaundice?" I asked that student to revise his notes again. Any jaundice, if the child is receiving phototherapy, means the TSB was high enough to warrant therapy. And any jaundice where you treat is not physiological. So I told him, by definition, it is pathological jaundice. Reason may be apparent, reason may not be apparent. It is something which will require investigation. Fortunately, the child became fine after a couple of days. Later on, it was found that there was mild degree of ABO incompatibility, which was not severe enough, but some incompatibility was there, which had been missed initially. The tests had not been done. Happens in hospitals sometimes. So, any jaundice where TSB is high. Sixth, yellow staining of palms and soles. If palms and soles are involved, we call it as pathological jaundice. And seventh, any neonatal jaundice associated with features of encephalopathy, that is CNS involvement agar ho gaya, then also we will call it as pathological jaundice. So any one out of these seven is the definition for pathological jaundice. Now, what are the major causes? There is a huge, massive list. You need not remember all. The major ones we'll be writing. So, what are the major causes of pathological jaundice? The first category is hemolysis. As a group, hemolysis is considered to be the most common cause. Among hemolysis, there can be causes like RH incompatibility, which is considered to be the single most common cause of pathological jaundice, overall also and in the first week as well. You can have EBO incompatibility, you can have minor blood group incompatibilities, you can have G6PD deficiency, and you can have hereditary spherocytosis. These are the major reasons. The second reason is congenital hypothyroidism. Thyroxine is required for multiple things. It facilitates the conjugation process. More importantly, it is involved in the uptake of unconjugated bilirubin from the blood by hepatocytes. So when thyroidism is there, this process will be affected. Then it can occur in cephalhematoma. What is cephalhematoma? It is large subperiosteal hemorrhage. All those extravasated RBCs, when they degrade, large amount of bilirubin will be released and that will cause jaundice in the child. It can occur in polycythemia. You know that polycythemia has increased RBC mass, so that will again contribute. It can occur with sepsis. Sepsis can cause both conjugated as well as unconjugated type of hyperbilirubinemias. It can occur with breast milk or breastfeeding. The jaundice associated with breastfeeding, which is pathological, is actually called as breast milk jaundice. More about it we'll talk later in this module. So, breast milk jaundice. So, exclusively breastfed child very rarely can develop pathological jaundice. And the next category is neonatal cholestasis. Neonatal cholestasis. Neonatal cholestasis, you know that cholestasis will mean conjugated hyperbilirubinemia. So, neonatal cholestasis and related causes of conjugated hyperbilirubinemia. We give it as a broad category. In this, you include conditions like extrahepatic biliary atresia, idiopathic neonatal hepatitis, congenital infections like Torch group of infections, hepatic syndromes like Ehlers-Danlos syndrome, tyrosinemia, alpha-1 antitrypsin deficiency, and galactosemia. So, this is the overall list which you need to remember. The major causes I have mentioned at one place. This is your NEET PG question, old NEET PG MCQ. Now, before we go further, let us discuss one MCQ example so that whatever you are reading, whatever you are listening, at least you should understand how this is asked in MCQs. Look at this MCQ example. The question says, a 3-day-old neonate presents with clinical jaundice. Okay, his TSB was done and showed a value of 8 mg per deciliter, which increased to 11.5 within 24 hours. The child had blood group of O negative and was clinically stable on exclusive breastfeed. What is the likely clinical possibility? And you have 4 options here. Physiological, breast milk, RH incompatibility, congenital hypothyroidism. Now, in MCQs like this, I'm also telling you the approach to solve MCQs on jaundice, right? Whenever you have a question like this, in neonatal jaundice, the first thing to see is whether it is physiological or pathological, right? Try to see. Pathological kya hoga? In pathological, 1 out of 7 criteria should be fulfilled. Visible jaundice in first 24 hours, not there in this question. Rapid rise in serum bilirubin. What is rapid rise? More than 5 mg in 24 hours. What is the rise here? 11.5 minus 8. So it is 3.5 milligram per deciliter in 24 hours. So there is no rapid rise. There is no yellow staining of palm and sole, no encephalopathy, no feature suggestive of any cholestasis has been mentioned, no prolongation of jaundice. So this child is no criteria of pathological is being fulfilled. So this child is having physiological jaundice. All children are on exclusive breastfeed, and so presence of breastfeed alone will not say that there is a physiological or pathological. Since no criteria of pathological is being fulfilled, by exclusion, the answer is A, physiological jaundice. Very similar question was asked in one of the entrance exam, and many of the students, despite reading the topic of NNJ, got it wrong because they just superficially read it. If you read it in a applied manner, there is no reason why you should not get this question correct. So this is an MCQ example. Moving over to how would you assess? Now continuing with our discussion, you have defined whether it is physiological or pathological. Now you need to assess the child. Assessment has two parts. One is clinical assessment and second is investigation. So whenever you have to do workup in a child with neonatal jaundice, the first thing we do is clinical assessment. Clinical assessment. And clinical assessment is done by a rule called as modified Kramer's rule. Modified Kramer's rule. It is also called as Kramer's dermal staining method. Kramer says that jaundice begins from head and neck and goes to the periphery. So in any child, you can divide the whole body into 5 zones. I am making a very crude diagram so that you are able to understand crudely. You don't need to go too deep into it. So zone 1 is your head and neck, right? Zone 2 is part of trunk above the umbilicus. Zone 3 is part of trunk below the umbilicus up to knee joint. So it includes the thighs also. Zone 4 are the lower limb below knee joint as well as the entire upper limb. And zone 5 are palms and sole. These are the 5 zones. Kramer says when jaundice begins and it is in physiological range, it starts from here and is usually present here. As TSB further rises, it goes on appearing in the zone 3, then zone 4 and finally zone 5. So this progression tells you what is the approximate TSB. Earlier, there was a single simple table for this, but AIMS Protocol 2019 made it a bit complex, saying that if a jaundice is in this zone, this should be the value. If it is lemon yellow color, this is the value. If it is deep orange yellow color, it is this value. So what does the AIMS Protocol say? AIMS Protocol says, on one side you write zone, then you write approximate TSB level. Mind you, you are not yet investigating. Abhi blood nahi nikala hai. You are simply doing it based upon clinical assessment. Approximate TSB level, you can make further 2 categories. What is the skin color? Whether it is lemon yellow skin color or it is orange yellow skin color. It is not a very right thing to say, but that is how the protocol is. So Kramer rule says if it is jaundice is present only in zone 1, the corresponding TSB value, if it is lemon yellow skin, it is 5 to 7 milligram per deciliter. And if it is orange yellow, it is 7 to 9 milligram per deciliter. Similarly, for zone 2, it is 7 to 9 and 9 to 11. For zone 3, it is 9 to 11. In every zone, orange yellow wala is coming into the next mild jaundice, lemon yellow color zone. So 9 to 11, 11 to 13. Zone 4 is 11 to 13 and 14 to 16. And here, zone 5, it is 14 to 16 and equal to or more than 17. So this is the table, not asked so far, but part of protocol, changed protocol. So cram up karna padega. So you will have to cram it up, but it is a small little thing if you are understanding everything else in a oriented manner. Now, the second part of workup is the investigations. Investigations. In investigations, the first line investigation is always TSB, that is total serum bilirubin. It is the first thing to be done. If TSB is within normal limits and the rapid rise etc. is not there, it is physiological, you don't need to do any other investigation. But if you are doing, and if there is a suspicion of pathological jaundice, then you will do second line investigation also. Second line investigation includes ABO and RH grouping. You will do a complete hemogram, including peripheral smear. You will do liver function test, including checking for direct fraction. So conjugated fraction is checked in a second line investigation, not first line. It is a mistake people make when it is asked specifically in vivas and in old MCQ also. Then you will do a DCT, that is direct Coombs test, to check for immune mediated hemolysis. You will do G6PD levels. So these are and further tests will be decided based upon what abnormality is being seen. Now there is a new screening tool. So you would write new screening tool available for checking bilirubin. Many parents are very apprehensive. You don't take out blood in our child. This is just, suppose, imagine, resource limitation is not there. Parents are well off. Child is in a tertiary care center or in a corporate hospital, and you see that the child does not have any risk factor, term baby. Only mild jaundice is present in the head and neck and in the maybe in the upper part of trunk. Parents do not want to give their assent for taking out blood in the child. So what you will do? There is a screening tool you can use. Although it is not yet validated, but it is being increasingly used. The screening tool is called as transcutaneous bilirubinometer. It is a handheld device. Without taking out blood of the child, you can check, it can tell you the approximate blood by looking at the spectral analysis of blood flowing in superficial capillaries. So you may get a photograph like this. Look at this procedure. What procedure is being done? This is not temperature which is being checked. This is a bilirubinometer telling you the approximate TSB in the child. Transcutaneous bilirubinometry is written as TCB. TSB is total serum. TCB is written for transcutaneous bilirubinometry. Transcutaneous bilirubinometry is not effective. It is not used in the following conditions. If the child is less than 35 weeks, it is not accurate. If the child is aged less than 24 hours, it is not useful. If the child is already on phototherapy, it is not useful. And if the TSB level is more than 12 to 14 milligram per deciliter in very high TSB, again it produces an erroneous value. So again, what it means is, if TCB shows a value of 13, 14, 15, you need to confirm it by doing a TSB. So these are the things which can be asked in MCQ entrance exam or even in your file. So moving from this screening tool, let's move towards the complications of neonatal jaundice. Complications of neonatal jaundice. Why would the complication arise? Majorly the complications are seen due to CNS involvement, and the complication seen in newborn is called as BIND. BIND stands for bilirubin induced neurological, some books say damage, some say dysfunction. So bilirubin induced neurological damage. Why does it happen? Whenever there is increased unconjugated bilirubin, it will cross the blood-brain barrier and cause CNS damage. This is why BIND happens. BIND is of two types. You can have acute BIND and you can have long-term BIND or its sequelae. Acute BIND is also called as acute bilirubin encephalopathy. Acute bilirubin encephalopathy, acute damage, acute manifestations of bilirubin. It is divided into three stages. The stage 1 will have features like lethargy, hypotonia, so decreased tone will be there, decreased feeding will be there or decreased sucking, and there will be bulging fontanelle. You know anterior fontanelle, right? Because of raised intracranial pressure, that will bulge out to the outside. Next is stage 2. In stage 2, there will be seizures and the tone which had decreased will now be increased. So hypertonia will be seen. But the key point to know is this hypertonia is more in the back of the body than the front. So imagine a child, normal newborn, he tends to adopt a slightly flexed posture. But if the tone here is high, what will happen? The neck will arch backwards like this. This is called as retrocolis, backward arching of the neck. So the child will have retrocolis due to hypertonia, that is backward arching of the neck. And second, the back will become hyperextended, stiff. That is called as opisthotonous posturing. Opisthotonous posturing. They are very dramatic. Stage 3 is the advanced stage, very high mortality. In this stage, there will be upper motor neuron signs. Babinski sign will be positive. The child will have spasticity in the limbs. There will be shrill cry. The child will have apneic episodes, and there will be posturing. Decorticate or decerebrate posturing will occur, and death may occur in many of these children. So these are the 3 stages of acute bilirubin encephalopathy. Remember that stage 1 is reversible provided urgent life-saving measures are taken. Stage 2 may or may not be reversible. Stage 3 is always irreversible. The outcome in this is very grim. And that is why identification and proper management of jaundice, especially the acute encephalopathy part, is critical. After talking about this, let us have a look at how MCQ can be asked. You may get a question showing the following. They would say, a child with jaundice reaching up to palms and soles is seen with the following posture. Look at the posture and tell the likely diagnosis. Can you see that there is backward arching of neck? There is backward arching of neck and there is opisthotonous posturing. So what is the diagnosis? The diagnosis in this child is stage 2 acute bilirubin encephalopathy. There is a similar entity where jaundice is not there, but retrocolis and backward arching of neck and opisthotonous posturing can be seen. A differential diagnosis of that is neonatal tetanus. But neonatal tetanus is more of a theoretical. These days we don't come across neonatal tetanus due to the hygienic practices into play. This still happens. And question will tell you that there is jaundice or a background of jaundice with this child having the following posture. So the diagnosis here will be acute bilirubin encephalopathy stage 2. Now moving over to the long-term complication. The long-term complication or sequela of bind is called as kernicterus. Kernicterus is an older term which was initially called as yellow-white staining or yellow-brown staining of basal ganglia. The term kernicterus has now been replaced. There are 2 alternative terms which are used for this. It is also known as chronic irreversible bind. Irreversible is the word. And some people also call it as stage 4 bind. Although this term is not very popular in India. East Europeans are fond of it. So stage 4 bind. How do I know that? It's mentioned. I've read about it. I haven't been to East Europe, but this is what all these anecdotes, the terminology, different countries have a different way of pronouncing, different way of using the terms. So kernicterus, alternative names, they all mean the same thing. The MCQs which you need to remember in kernicterus, what is the most common site of damage? Is basal ganglia. This is your NEET PG question already asked in the past. And if you do MRI, you will find hyperintensities particularly on T2 images in bilateral basal ganglia. What are the features of kernicterus? The features include development of extrapyramidal cerebral palsy. What is extrapyramidal cerebral palsy? We have discussed in the TNS part. It is also called as choriothetoid cerebral palsy. They will have sensory neural hearing loss. They have upward gaze palsy. And they have dental dysplasia. Treatment in these patients is only supportive. There is not much you can do, and the quality of life lifelong is very poor. So proper management is important, and Which brings us to what are the therapeutic modalities. So let us discuss. There are, broadly speaking, two major therapeutic modalities which are approved for use. Others are only experimental. Please remember that. The two therapeutic modalities useful, one is phototherapy, where blue-green light is used. It is non-invasive but slow acting. And second is exchange transfusion, where we actively exchange the whole blood of the child. Since technical name for this is also called as double volume exchange transfusion, DVET. So these are the only two therapeutic modalities allowed to be used in these children. Before we go to the details of these therapeutic modalities, there are a few points that you need to remember. The few points are: never stop feeding in the child, including breastfeed. So breastfeed should never be stopped. There is no role of phenobarbital in neonatal jaundice, except there is one condition. Neonatal jaundice due to Crigler-Najjar syndrome. You remember Crigler-Najjar? The inherited unconjugated hyperbilirubinemia. Crigler-Najjar syndrome type 2, it is the drug of choice. It is effective in that category where the UDPGT activity is less, and so it can increase the activity. In normal children, there is no role of phenobarbital. There is no role of sunlight. Interesting thing is, many non-pediatricians, including doctors, sometimes do not understand this. The role of sunlight is not there when you treat a patient with jaundice. But we allow it because it is not causing any harm, provided the child is saved from the sunburns. Why is it so? It is written in all the standard textbooks, including AIMS protocol. See, I'll give you an example. I have a fever, so ideally I should take paracetamol, right? My dose, according to my body weight, will be somewhere around 500 to 600 milligram paracetamol. But instead of 500 milligram, I take only 5 milligram of paracetamol. So technically, I have taken paracetamol. But practically, is it going to decrease my fever? The answer is no. It is as good as not taking at all. On the other hand, it will produce a false belief that I have taken paracetamol. So if I have taken, the other person would try to convince me that you have taken wrong dose, it is not going to be effective. But since I have taken already, he would advise me you should go in for other therapies or cold sponging or whatever. This is an analogy for the sunlight. Theoretically speaking, the sunlight can have effect like phototherapy and it can decrease the TSB. But the spectrum which is there in sunlight is not good enough and you require continuous sunlight to the baby. The amount of sunlight needed to decrease bilirubin is so high that it will cause sunburns before actual effect happens. So you give sunlight, you don't discourage the parents because they are okay, the child is getting some sunlight, but we also ensure that danger signs are explained and any rise in bilirubin do not depend upon sunlight, go towards proper management of jaundice. So that is why the protocols are very clear, no role of sunlight in actual practical scenario. Another small thing, this is something I find written in many books, use of IVIG. See, corporate hospitals use IVIG, but what is the basis? Theoretically, they say that IVIG binds to FC receptor of immunoglobulins and so it decreases hemolysis. But whether you read Nelson or you read Avery or you read AIMS Protocol 2019, they all say that the use of IVIG is controversial. In fact, some of the recent studies say the effect is not that great. But still, when we have nothing else to do, we give a trial of IVIG. But IVIG is not a part of established therapeutic modality. And lastly, what is true regarding the use of metalloporphyrins? There is a category of drugs which are waiting to be approved since last many years, but they are not yet clinically approved. They inhibit heme oxygenase. So biliverdin will not form and hence bilirubin will not form, but they are toxic and not yet approved for use. So all these points, now when you will be solving MCQs, you will be coming across them. So you should know the context they are being talked about. And some of these points are mentioned wrong in many of the guides. They're not wrong in exact sense. It is just that they're not updated. All points which I have mentioned, they are based upon IMS protocol, OP-GHAI, and clinical protocol followed in PGI Chandigarh, the Blue Book PGI. Now moving over to phototherapy. Let us talk about phototherapy. Phototherapy details are asked in exam. How does phototherapy help? I hope you have seen. You may get a photograph like this and they will ask you what is being done. Phototherapy is being given for neonatal jaundice. You cover the eyes and genitalia and continuously phototherapy is given. Child taken out of machine only for feeding, otherwise it is not taken out. What is the principle of phototherapy? When we use blue-green light in the wavelength of 460 to 490 nanometers and with the irradiance of equal to or more than 30 microwatt per centimeter square per nanometer, we find that this blue-green light is freely filtered across the skin. It reaches blood and starts converting the circulating unconjugated bilirubin directly into polar compounds. These polar compounds are water soluble and so they are excreted from the body. So without involving liver, it provides alternate path for unconjugated bilirubin to be removed from the body. And so it is effective in all types of unconjugated hyperbilirubinemias. What is the mechanism? How does it act? There are three mechanisms which are proposed. The first mechanism is structural isomerization. In structural isomerization, unconjugated bilirubin is converted irreversibly into lumirubin. This lumirubin is then excreted from the body. Structural isomerization is considered to be the most important mechanism. 3 MCQs on this have been asked. The second mechanism is photoisomerization. It is also called as configurational isomerization or configurational mechanism. Here, the Z isomers of bilirubin are converted into F isomers. And these E isomers can be excreted. However, the problem is this is a reversible thing. And even if the phototherapy is interrupted for a few minutes or seconds, it reverts back. Third is your photooxidation. This is found to be the least important mechanism. So all the three are there, but the most important one is structural isomerization. And what is the distance of phototherapy machine when you keep it? The distance is 30 to 45 centimeters. Can be asked as a standalone fact-based question. Phototherapy is very effective, but it has a disadvantage. The disadvantage of phototherapy is it is not very effective if acute bilirubin encephalopathy has already started because it is slow acting. So it cannot reverse stage 1 encephalopathy, which is the reversible stage. And finally, there are some side effects that you need to remember. The side effects of phototherapy, they include diarrhea, dehydration. It includes dehydration can further cause electrolyte imbalance. There can be retinal toxicity. Although the eyes of the child are supposed to be covered, and if they're properly covered, it doesn't happen. Then temperature disturbances, hypo and hyperthermia can develop, and there is a thing, I'm using a colorful pen, side effect called as bronze baby syndrome. Bronze baby syndrome. What is bronze baby syndrome? The skin of the color of the child becomes like bronze. So parents fight with you. We gave you a fair child, you color of the skin. Indians are very particular about color, skin color. I don't know why. But bronze baby syndrome, this problem arises. So you have to reassure the parents that it is a transient discoloration and it will improve in the next 1 to 2 months. Why does bronze baby syndrome happen? It is a reversible complication, but it happens when the child already has conjugated bilirubin also. And conjugated bilirubin then forms bronze colored porphyrin pigments, which give a discoloration. Why would it happen? Many children will have a mixed type of bilirubin due to any underlying cause. It is a rare thing, but it can happen. So there is the unconjugated bilirubin by phototherapy will be removed. but the conjugated will form porphyrin pigments. They stay in the skin for around 1 to 2 months, and for 1 to 2 months, the skin color becomes changed. That is bronze baby syndrome. Now, which wavelength to use is very controversial. Different books say different thing. Nelson says something else. Guy says something else. Which is to be used? So, we'll take the help of AIMS Protocol 2019. Same thing is mentioned in PGI Blue Book as well. AIMS Protocol says irradiance should be more than 30 microwatt per centimeter square per nanometer. We already know. Range should be 460 to 490, or what is it saying? Must be ensured. Must be ensured means has to be 460 to 490. This wavelength is according to the skin color which has been done in the studies done in Indian children. What Nelson says is true for the Western population. When there is a mismatch between the two and specific protocols for our country are available, you will go with that. And so 460 to 490 nanometers is the one you should follow. In fact, other than Nelson, many of the other Western textbooks are also now going towards this value. So 460 to 490 will be your better answer for entrance exam. And also remember that when you give phototherapy, LED lamp is always preferred over the CFL lamp. Now, few words about double volume exchange transfusion. You give phototherapy, the child's bilirubin does not improve beyond a certain point, or you find that stage 1 bilirubin encephalopathy has started. Now you have to save the life of the child. For that, we change the blood of the child. What is the principle? You remove baby's entire blood. It will do two things. One, it will remove the unconjugated bilirubin rich plasma. So bilirubin will fall. Also, if there is immune hemolysis going on, it will remove the antibodies, and so it will stop the disease process itself. So it is more effective and life-saving than phototherapy. Has problems of blood being there is a risk of transfusion, can be done only in tertiary care setting, but it is life-saving when phototherapy fails. So what is the principle of double volume exchange transfusion? The principle is you remove and exchange baby's blood. Because two cycles are performed in same setting, we call it as double volume. Double volume does not mean you take out 100 ml, give 200 ml. Child will die of CCF. Two cycle means you do the cycle 2 times very slowly in the same setting. So the name is called as double volume exchange transfusion. How does it help? Acutely, it removes the unconjugated bilirubin rich plasma. So there is a rapid fall total serum bilirubin levels, which can reverse stage 1 acute bilirubin encephalopathy. Over long term, this removes the antibodies causing immune-mediated hemolysis. Immune-mediated hemolysis. How to calculate how much blood should be used for double volume exchange transfusion? There is a formula for that, but the formula for that is, I'm writing on the side. You can remember like this. The normal blood volume of a newborn is given by the formula 80 to 90 ml per kg. If I ask you what is your blood volume or my blood volume, it is 5 to 6 liter in adult. Newborn depends upon the weight. So normal newborn blood volume kitna hoga? Can be a standalone MCQ also. It is 80 to 90 ml per kg. Here we are using 2 cycles. So volume needed for DVET will be, kitna blood mangwayenge aap from blood bank? It will be twice of this, that is 160 to 180 ml per kg. Can be a potential MCQ, can be a potential numerical question. It is more effective overall, but it is less, but it is invasive. So what is the technique? Name of the technique which is used to do it? The name of the technique is push-pull technique. You take out in small amounts from the baby and you give in small amounts simultaneously. The blood to be used, it is ideally cross-matched. If nothing is available, O negative blood group, O negative blood can be used. Cross-matched is ideal. In emergency, you can use O negative blood also. And what are the side effects of double volume exchange transfusion? There is a risk of nosocomial sepsis. Nosocomial sepsis can develop in the child. There is a risk of Hypocalcemia, statement-based question on this has been asked. Why hypocalcemia develops? Because when you give large amount of transfused blood, citrate in blood will bind and chelate ionized calcium. So hypocalcemic tetany can develop. You will have a side effect of hyperkalemia. Stored blood is rich in potassium. It is an intracellular ion, moves out when the blood is stored, and there is a risk of blood-borne infections, HIV, hepatitis C, hepatitis B, and finally, there is a problem of volume overload or shock. Too much of blood given, volume overload, too less blood given than it was taken out, shock can develop. So these are the problems you see with double volume exchange transfusion. So coming to the management of neonatal jaundice, the management protocol we follow is AIMS protocol 2019. It is a huge protocol. I will keep it simple. AIMS protocol says you first define what is serious jaundice. So now a new term is coming called as serious jaundice. What is serious jaundice? Any one of the following is called as serious jaundice. Now we are into therapy zone, right? Either visible neonatal jaundice in first 24 hours of life, or if the child is having yellow palms and soles anytime, or the child has encephalopathy in jaundice, CNS involvement, or you have done TCB value, transcutaneous bilirubinometer, it is more than 95th centile. You plot it on charts. Charts are available, right? Any of this is present, this is called as serious jaundice. So AIMS protocol says when a child with jaundice comes to you, the first thing you do is look for serious jaundice. Look for serious jaundice. This is the first step you do. Now there will be two possibilities. Serious jaundice is present and serious jaundice is not present. If serious jaundice is present, first step will be start phototherapy. Don't waste time in investigation. Investigation will be done, but only after phototherapy has been started. It is a practical approach because a lot of time is wasted in sending the report, getting it, and if the child has pathological jaundice, serious jaundice, it can cause serious damage in the meanwhile. Phototherapy kya hai? Even if you have over calculated and you have started and you find that later TSB investigation everything is fine, switch off the machine, make the child out of the phototherapy machine. But starting phototherapy in serious jaundice is the first step, and only after that you will go in for performing. As a second step you will do investigation. The first investigation you will do is total serum bilirubin investigation. So first investigation is TSB, but first step in serious jaundice is starting phototherapy. If the answer is no, you will use Kramer's rule. Clinically you will see if TSB is needed. If you feel TSB abhi sirf head and neck mein hai, it is not needed, you may not do it. So if the answer is no, you will only observe the child. If the answer is yes, then you will perform TSB and you will take a clinical decision. 2 MCQs on this have been asked, once in another exam and one in AIMS entrance exam in the recent past. So this protocol is very important. Next we come to when to use phototherapy and DVET in admitted children. There are different rules for term and preterm babies. Ideally, it is a clinical decision based upon AAP charts. American Academy of Pediatrics has given charts. This is how the chart looks like. So you will calculate the TSB value, look at the age of the child, you will plot and see where does the child lie, and then you will take a decision. So this is the lower risk zone, this is the medium risk zone, this is the high risk curve, and you will take a clinical decision based upon that. In other words, in MCQs you will not get this. What you will get is the practical indications, what we practically do. What we do. This is something which was recently asked in last NEET PG also. So practically, you have the first category, children equal to or more than 35 weeks of gestation, right? You will form a small table. Age, other side, you would write the minimum TSB to start phototherapy. If age of the child is 24 hours of life, the minimum TSB to start phototherapy is equal to or more than 10 mg per deciliter. In 48 hours, it is equal to or more than 13. 72 hours, it is equal to or more than 15. And 96 hours and beyond, it is equal to or more than 18 milligram per deciliter. Generally, we say exchange transfusion values are 3, 4 or 5 milligram per deciliter higher, but again, it is a very crude rule. This rule we usually use reserve for when to start phototherapy. 3 MCQs on this have been asked as clinical cases entrance exam, including previous NEET PG exam. And then you have indications of DVT. See the DVT kab karenge? If the cord hemoglobin is less than 10 gram per deciliter, or if the cord TSB is equal to or more than 5 milligram per deciliter, if the rate of rise in TSB is equal to or more than 1 milligram per deciliter per hour despite phototherapy, if the child is having fetal hydrops due to incompatibility, if the child is having TSB in high risk DVET zone according to ARP charts, and finally, if the child is having previous sibling needed DVT plus current sibling, the present child is having pallor, hepatosplenomegaly and direct Coombs test, then you will do DVET. But this is something which is difficult to implement in case of MCQ entrance questions. All they will ask you is which of the following is an indication or which of the following is not an indication to do DVET. Moving over towards preterm babies, remember that in preterm babies, there are tables we tend to follow. There is a general rule which says that phototherapy is started if the total serum bilirubin level is more than 1% of the birth weight of the child in grams. So, any preterm child less than 35 weeks. Here, because more than 35, we have already done the table. So, preterm babies and low birth weight newborns who are less than 35 weeks, that is what we are talking about. So, you have a preterm child, his weight is 900 grams. So, 1% of that will be 9. So, if the TSB level is more than 9 in that child, you will start phototherapy. And the exchange transfusion will be started when there is phototherapy cutoff, which you have decided abhi using this formula +5. So, if you add +5 to that, that is your exchange transfusion zone. In general, there is a table for that as well. If it is less than 28 weeks, you can make this small table. Phototherapy will be started for 5 to 6 milligram per deciliter, and DVET is given for 11 to 14 milligram per deciliter. You have to cram them up. These are tables given in GHAI and AIMS protocol. If the child is 28 to 31 weeks, this is an abbreviated table. It is 6 to 10 and DVET value is 12 to 16. If it is 32 to 34 weeks, then it is 10 to 12 and here it is 15 to 16 to 18. And if it is more than 34 weeks, the value will be 12 to 14 here and equal to or more than 18 here. So, this is the values you are supposed to remember as a extra edge thing. Let us try to look at some MCQ examples and see whether we are able to solve whatever we have discussed or not. So, MCQ example, this is AIMS style. Let us see. A baby born to O positive mother was found to be icteric on the day of birth. What is the immediate next step in management? 4 options were given. So, this is AIMS style question. Any child coming to you, AIMS protocol says, look at whether it is serious jaundice or not. Is it serious jaundice? The answer is yes. There is icterus or jaundice on day 1 of life. So, it is serious jaundice, and in serious jaundice, what is the first step in management? Start phototherapy, then perform investigation. So, answer to this question is C, starting phototherapy. So, pause here, go back to protocol which I showed and come back again and continue the discussion. The second question, 2700 gram term baby, well fed and exclusively breastfed, was found to be icteric with TSB of 14 on day 5 of life. What is the management? We have already done the cutoff to start phototherapy in term baby. 24 hour पे it is equal to more than 10, 48 hours it is equal to more than 13, 72 hour equal to more than 15, and 96 hours and beyond it is equal to more than 18. This is day 5 and so the cutoff to start phototherapy is 18. यहाँ कितना है 14. So cutoff has not yet been reached and so only observation is needed in this child. This was the recent NEET PG question asked in exam. Question number 3. 3-day-old neonate is brought by mother to pediatrician and is found to have a bilirubin of 18 milligram. It should be milligram per deciliter. What is the next step in management? Now, stopping breastfeeding can never be the answer. You never stop breastfeeding. Another option with stopping breastfeeding will already be ruled out. Now we are left with B and D. Look, think of that category again. 3-day-old neonate is found to have bilirubin of 18 milligram per deciliter. So 24 hour 10, 48 hour 13, 72 hour 15, 96 hour 18. And value of exchange transfusion is around 4 to 5 in addition to that. This child is having 18, it is more than 15 and so you will start phototherapy in this child. This is how questions are asked in entrance exam. Then fourth question, all of the following affect effectiveness of phototherapy except, remember, phototherapy does not depend upon the skin color. There is no racial discrimination in phototherapy. So answer to this question is skin pigmentation. Initial level of serum bilirubin, phototherapy results can be affected. Irradiance, we have said it is more than 30 hona chahiye. Type of lamp, we know that CFL lamps are less useful, LED lamps are better. So skin pigmentation does not affect effectiveness of phototherapy. Mechanism of phototherapy responsible for reduction in jaundice. You know already, one-liner, structural isomerization has been asked in both AIIMS and NEET PG. And premature newborn, born at 32 weeks, having birth weight of 900 gram, developed jaundice on day 3 of life. TSB found to be 15 milligram per deciliter. What is the therapy of choice? If you remember that between the age group of 32 to 34 weeks, look at the table which we had formed. Phototherapy will be given for value between 10 to 12 and exchange transfusion is done for value between 15 to 18. 15 value has been attained and so you will need to perform exchange transfusion in this child. All these questions can be solved provided the protocols, the tables I have taught you are there in your mind. And then you have the hot new thing. What is the role of IV hydration in neonatal jaundice? There are certain children who will have features of dehydration and the bilirubin will be high. In these patients, it is found that if you do IV hydration, the need for exchange transfusion is decreased. So any child, any neonatal jaundice who's having TSB in DVET zone when you plot on the chart, but is also having dehydration, when you give IV fluids, कितना IV fluid देना है? In addition to maintenance fluids, you will use N/3 saline, special saline आता है, N/3 saline in a dose of 50 ml per kilogram, given slowly as infusion over 8 hours. It has been shown to be life-saving and it also decreases the need for DVET. So this is the new thing that you need to remember. Next we come to prolonged jaundice in case of neonates. So what is prolonged jaundice? The definition says any neonatal jaundice lasting more than 2 weeks in term babies and more than 3 weeks in preterm babies is called as prolonged jaundice. What are the common causes? The common causes include breastfeeding jaundice. What is this? We'll discuss in some time. Second is breast milk jaundice. Third, it can occur due to neonatal cholestasis. And fourth, it can occur due to ongoing hemolysis. Ongoing hemolysis, for example, any incompatibility reaction. Sometimes it can also occur due to congenital hypothyroidism, inherited conditions like Crigler-Najjar syndrome and Gilbert syndrome, and it can occur due to Kaffel hematoma. Rarely it can be seen in GI obstruction, for example, malrotation. All these are taken from the AIIMS protocol. So a child is having prolonged jaundice. How you are going to manage that child? What is the approach? Approach is very simple. First thing is rule out cholestasis. How you will rule out? Clinically, you will look for, whenever there is cholestasis, you know that the child will be having dark colored urine and clay colored stools. So you will rule them out. And ideally, you will do investigation and look for direct fraction of bilirubin. So you will perform the liver function test. After doing that, if the child is having cholestasis, you will manage accordingly. If the child is having no cholestasis, the possibilities can either be due to exclusive breastfeeding or it can be due to the other rare causes. And so you will need to investigate for each cause separately. So approach to prolonged jaundice, what is the next step to do? This is how question can be asked. And finally, we come to neonatal jaundice associated with exclusive breastfeeding. Now, it is found that children who are exclusively breastfed, they are found to have higher circulating bilirubin levels than non-breastfed babies. This exclusive breastfeeding jaundice can be categorized into two types. One is called as breastfeeding jaundice. In short, it is written as BFJ. And second is breast milk jaundice, written as BMJ. Now, breastfeeding jaundice is, how do we distinguish between the two? Let us do it in a descriptive manner. Breastfeeding jaundice is more common. It is mild, whereas breast milk jaundice is rare and severe. Second thing, breastfeeding jaundice, there is no risk of CNS damage, whereas in breast milk jaundice, it can cause bilirubin-induced neurological dysfunction. So CNS damage can happen. Very important point. What is the time of appearance? It appears in the first week of life. First week of life. What is the exact time when this jaundice becomes apparent? It becomes apparent between, most commonly, 5th to 7th day of life. Whereas breast milk jaundice, the time of appearance is between beginning of 2nd week up to 4th week of life. So it tends to present never in the first week of life. What is the cause of breastfeeding jaundice? The cause is inadequate feeding. So due to inadequate feeding, there is dehydration in the child, which causes hemoconcentration, producing increased TSB levels. Plus, this decreased feeding also causes decreased stool volume. Decreased stool volume and frequency causes increased enterohepatic circulation. And so, it results in mild elevation in total serum bilirubin. What is the treatment? The treatment is very simple. Increase the feeds. You increase the feeds and the child will be fine. So, it is a problem associated with feeding. So, feeding mein problem hai. Whereas on the other side, breast milk jaundice, milk has a problem. So, what is the cause of breast milk jaundice? The cause is substances in breast milk. What are substances? There are two types of substances in breast milk which cause this disease. One, sometimes there is occurrence of substances called as beta glucuronidases. These beta glucuronidases, they convert the conjugation जो भी हुआ back into unconjugated, right? So it will cause massive elevation in the total serum bilirubin levels. Plus, sometimes also there is occurrence of substances which inhibit conjugation, inhibit conjugating ability. For example, the substances called as pregnanediol, free fatty acids, They cause inhibition of conjugation and so result in increased total serum bilirubin. What is the treatment in these patients? Earlier, the treatment used to be you stop feed and start with the let the adverse time tide over. But now we know, earlier the therapy was you stop breastfeeding and let the adverse time tide over. Now we say AIMS protocol clearly says feeding is always to be continued. You give aggressive phototherapy and double volume exchange transfusion. If the acute phase is over, the child usually comes out of it. So treatment will be continue the feeds. Do not stop feeds. Although very rare cases, very high bilirubin 20 to 23, and the child is not in a tertiary care center, you can switch the child to formula feed or IV fluids for some time till the child is admitted to a tertiary care center, but that is more of an exception. Ideally, you should continue feeds and give aggressive phototherapy and double volume exchange transfusion, and it is seen that if that period of 2 to 4 weeks is tided over, the child usually comes out of it. Nature is like that. Breast milk jaundice does not occur after 4 weeks of life, even if the breastfeeding is continued. So these are the two types of jaundice. You can get MCQs based upon these. So this finishes our entire spectrum of neonatal jaundice. Things related to biliary atresia and conjugated hyperbilirubinemia is discussed separately in the next module. Let us briefly discuss a topic which is important, that is neonatal cholestasis. If you look at Nelson 21st edition defines neonatal cholestasis biochemically. Nelson 21st edition says that neonatal cholestasis is defined biochemically as prolonged elevation of serum conjugated bilirubin. Serum conjugated bilirubin in a newborn beyond first 14 days of life. That is defined to be neonatal cholestasis. So, prolonged elevation of serum conjugated bilirubin means it is also sometimes written as conjugated hyperbilirubinemia. So, any newborn who is showing conjugated hyperbilirubinemia beyond 14 days of life is defined to have neonatal cholestasis. Now, obviously, the question arises, how do you define conjugated hyperbilirubinemia? So, I am giving the heading conjugated hyperbilirubinemia in a neonate. There is a very useful concept here. When I say conjugated hyperbilirubinemia, many students tend to think that it means that conjugated fraction is more than unconjugated fraction. That is not always true. Suppose you have a kid, the child's total bilirubin is 10, unconjugated 7, conjugated 3. So when you look, you find that unconjugated is more than conjugated. So if I ask what type of jaundice is it, they would say, sir, it is predominantly unconjugated. That is wrong. I would call it as conjugated hyperbilirubinemia. Why? Because conjugated fraction is 3 out of total 10. 3 out of 10 means 30%. The cutoff to define conjugated hyperbilirubinemia is anything more than 20%. So the definition says, in a newborn, if the conjugated bilirubin, also called as the direct fraction, if it is equal to or more than 20% of the total serum bilirubin, we call it as conjugated hyperbilirubinemia. This can be asked directly, this can be asked as a part of a clinical case. Additionally, any neonate with icterus, any neonate with clinical icterus, that is jaundice, if the absolute value of conjugated bilirubin is equal to or more than 2 mg per deciliter, that is also defined to be conjugated hyperbilirubinemia. So these are the definitions for conjugated hyperbilirubinemia, and conjugated bilirubin lasting 14 days or longer in the neonatal period is called as neonatal cholestasis. Remember that conjugated hyperbilirubinemia is always pathological in newborns. Unconjugated can be physiological or pathological, but conjugated jaundice in newborn is always pathological. This is the first thing that you need to understand. Now moving over to the common causes of neonatal cholestasis. The causes can be divided broadly into two types. We can have the intrahepatic causes and we can have the extrahepatic causes. The intrahepatic causes, there can be multiple subcategories here. So we'll keep it simple. The first common reason is idiopathic neonatal hepatitis. Second cause are metabolic disorders. What are the metabolic disorders? The common ones include galactosemia, tyrosinemia, alpha-1 antitrypsin deficiency, and cystic fibrosis. The third category are infections. The common infections which can cause neonatal cholestasis, they include torch group of infections, Epstein-Barr virus. They are the common groups. Then it can occur due to genetic disorders, which includes conditions like Ehlers-Danlos syndrome. Ehlers-Danlos syndrome. It can occur due to total parenteral nutrition, and it can occur due to mitochondrial disorders. Finally, there is a group of conditions called as PFIC. PFIC stands for Progressive Familial Intrahepatic Cholestasis. It is something we have discussed separately, briefly, in one of the pediatric hepatology modules. So you can have the details there. So these are the common intrahepatic causes. On the other hand, we have extrahepatic causes. Extrahepatic are very limited. Extrahepatic includes the classic example, that is extrahepatic biliary atresia, also sometimes written simply as biliary atresia, EHBA. It also includes choledochal cyst, and it includes a syndrome called as inspissated bile duct syndrome. So these are the common causes of neonatal cholestasis. Potential MCQ, and it is a controversial one. What is the most common cause of neonatal cholestasis? Traditionally, it used to be idiopathic neonatal hepatitis, but now OP-Ghai, some parts of Nelson, the new Nelson is silent upon it, but the pre-test and the older Nelson, as well as studies from AIIMS and study published in Indian Pediatrics, combining all the studies which have been done in India as well as abroad, they all are in unison. They say that most common cause of neonatal cholestasis is extrahepatic biliary atresia. Earlier, when I was a student, it used to be idiopathic neonatal hepatitis. This is because as advances in evaluation are happening, it is being found that many of the patients who were labeled as idiopathic neonatal hepatitis actually are found to have some disorder, and so the percentage of neonatal hepatitis is falling. And somebody asks you, most common cause of neonatal cholestasis, it is biliary atresia. And the second common is idiopathic neonatal hepatitis. There have been controversy on this when I have answered students, and students have said, sir, but somebody was saying the other thing. I have taken snapshots from studies which are latest, which are standard, and which will be incorporated in the upcoming editions. Some of them are already there in the upcoming editions. Ghai snapshot I have not taken. 9th edition Ghai you can always read. Western studies, already biliary atresia was most common since beginning. Overall also biliary atresia is there. So the most common cause they have mentioned, it is biliary atresia in this study, followed by others. Similarly, this is an Indian study combining all the studies, including those the tertiary care centers like AIIMS, PGI and Sanjay Gandhi PGI Lucknow, and they all say that biliary atresia comprises 34%, followed by unknown etiology, that is the hepatocellular cause, also called as idiopathic neonatal hepatitis in 30% cases, and then you have infections in 17%. So the most common cause is extrahepatic biliary atresia. After this, we move towards the proper topic, biliary atresia, because it is a high yielding topic. Biliary atresia Extrahepatic biliary atresia are synonymously used. There is a technical name for that as well. It is also called as non-cystic obliterative cholangiopathy. So suppose you have a question of atresia and they put this as the option, don't get confused, they mean the same thing. This is a more glorified name of biliary atresia. Let us look at the anatomical classification. There are two types of classifications of atresia. One is anatomical, second is clinical. Anatomical is more commonly followed and this is the one you can understand easily. Let us look at a handmade picture I made of the biliary tree. These are the intrahepatic ducts, if you see. This is the common hepatic duct, which I made in purple. This is the cystic duct, which is in blue, and common hepatic duct and cystic duct are joining to form the green colored common bile duct, right? Now, biliary atresia is divided into broadly 4 types. First, you have type 1. This is the normal one, right? So, type 1. What happens in type 1? In type 1, the remaining biliary tree is normal, but the distal part of common bile duct, where it is opening into the duodenum, that gets obliterated. It is called as type 1 biliary atresia. Second category is type 2 biliary atresia, in which the common hepatic duct is the atretic part, which is the affected part. The remaining biliary tree is normal. It is called as type 2A. Then we have the third category, that is in which the common hepatic duct, the cystic duct as well as common bile duct, all three are obliterated, but the part of biliary tree inside the liver, the intrahepatic duct, are not affected. We call it as type 2B. And then we have the most severe form, that is type 3. In type 3, the entire biliary tree, including the intrahepatic duct, is also obliterated. So this is called as the anatomical classification of biliary atresia. I hope it is clear to you and you need not write it. You can simply make the diagram and remember like this. The second classification is the clinical classification. It is less commonly followed, but it includes an important syndrome. So it can be a extra edge question for your exam. So clinical classification says that there are 3 varieties. The first variety is the perinatal type. Perinatal type is the most common. It is seen in almost 70% cases and there is no associated malformation. The second category is the BASM or BASM syndrome type. BASM syndrome type, which is seen in 15% cases. What does BASM syndrome stands for? BASM stands for biliary atresia with splenic malformation. So there will be splenic abnormalities here. The common splenic abnormalities can include polysplenia. This type of syndrome is associated with polysplenia. Other than biliary atresia, they can have congenital heart disease of multiple types and they can have malrotation of the gut. Finally, they can also have situs inversus. So there will be associated malformations. Full form of BASM syndrome can be asked in entrance exam. And the third form is biliary atresia, which is associated with choledochal cyst. This is the form which is seen in another 15% cases, and this can also have renal and cardiac malformations. But the more common one is isolated, where the malformations are rare. So these are the 3 classifications. This classification is a bit less favored, less followed. But it is mentioned in all the books and so you need to remember this. Now moving over to the clinical features of biliary atresia. These are the children who will present in the neonatal period with prolongation of clinical jaundice. So they will have prolonged neonatal jaundice. Along with that, they will have the typical history which is seen for conjugated hyperbilirubinemias, cholestasis. They will have dark colored urine and clay colored stools. As time progresses, many of these children may tend to develop some failure to thrive. Not all of them have failure to thrive. Some of them may tend to develop failure to thrive. They may also develop progressive hepatosplenomegaly. They tend to develop hepatosplenomegaly. And when you investigate They are found to have elevated direct fraction of bilirubin. When you perform investigations, what do you find in investigation? On investigation in extrahepatic biliary atresia, you will find that there is elevation in the cholestatic markers. What are the common cholestatic markers which are elevated? You will find that there is elevation in alkaline phosphatase, there is elevation in gamma glutamyl transpeptidase, and there will be elevation in 5-nucleotidase. So these will be elevated, right? But they are non-specific. Secondly, you will have ultrasonography. When you do ultrasound, it is a useful investigation and can rule out similar looking conditions. Remember that Nelson says that high frequency ultrasound is better than conventional ultrasonography. And since we are doing it in an integrated manner, so radiology thing also comes into play. What are the ultrasound markers of biliary atresia? They can include a sign called as triangular cord sign, which is present just above the portal bifurcation. There can be non-visualization of gallbladder. Any of these can happen. Non-visualization of gallbladder. And thirdly, there can be a small, the so-called micro gallbladder. So any of these can be seen in extrahepatic biliary atresia. The third investigation we do is scintigraphy. In scintigraphy, we use a scan known as HIDA scan. HIDA scan earlier used to be very popular. It has got high sensitivity, but it has low specificity. And it is more useful as a negative predictor. It is more useful to rule out other conditions rather than to say that biliary atresia is surely present. The problem with HIDA scan is you need to, there is a delay of 4 to 5 days when you perform the study, and there is also a need for preloading with phenobarbital. So it is cumbersome, needs phenobarbital preloading when you perform it, and the results take 5 days to be interpreted. So that is the problematic thing. Then you can have investigation, you do investigations like ERCP and MRCP. But ERCP and MRCP, they have a limited role in patients in newborns. They have a very limited role in newborns. They are better suited for older children. Now coming to the specific investigation known as liver biopsy. Liver biopsy is the most valuable investigation you can do in suspected patient of EHBA. It is the most specific investigation. It is also the most valuable investigation. Being a pediatrician and having worked in neonatal units, sometimes the difference between idiopathic neonatal hepatitis and biliary atresia is very difficult to make. And before you take up the patient for surgery, liver biopsy is the one that clinches the diagnosis. When you do liver biopsy, you find things like bile duct proliferation, fibrosis, bile plugs, as well as portal edema. The key important thing to remember here is, in patient of EHBA, the hepatic architecture is always intact. The lobular architecture is intact. The architecture is intact. Whereas in patients with neonatal hepatitis, the hepatic architecture is usually disrupted. So this is a useful clue for your MCQ entrance exam. And finally, we have final investigation known as intraoperative cholangiogram. Intraoperative cholangiogram is traditionally considered to be the gold standard investigation. During surgery, if you perform it, it shows the location and extent of atresia and is most accurate in delineating the disease. So it is always done during the surgery. Now, which one is the gold standard is something which is again has become very controversial. Traditionally, the teaching in pediatrics and even in pediatric surgery is that liver biopsy is the most accurate investigation and gold standard is cholangiogram. As you can see with these references, they all are saying that gold standard is intraoperative cholangiogram. Similarly, every textbook also talks about the same thing. However, a recent edition of Sebastian textbook of surgery mentions liver biopsy to be the gold standard, and that is why confusion has come. So I don't think this is something which is going to be asked specifically in the exam, but in view of it is something which comes down to what the author specifically means by gold standard. Gold standard is a test. Usually it may not be the most commonly done test or the ideal test, but it is a test which reasonably establishes the diagnosis, even if it is an invasive test. And because majority of pediatric texts talk about cholangiogram as the gold standard, I would say gold standard continues to be cholangiogram. However, there are references, I must admit, for liver biopsy as well. So it all comes down to the number of references which is favoring what. Majority of them favor cholangiogram as the answer. And so the better answer according to me is intraoperative cholangiogram. Now moving over to the treatment of biliary atresia. Treatment of biliary atresia, first of all, any patient of neonatal cholestasis, you will perform a general management. So the general therapy for neonatal cholestasis will include which is done for all types of neonatal cholestasis. You need to continue breastfeeding. Second, you need to give calories. You ensure that the calories are more than the recommended RDA. GAI says that 125 to 150% of RDA should be given, but practically in a breastfed child, it is difficult to calculate those calories. So what we actually do is we continue breastfeed as much as possible. Along with that, we add MCT oil supplementation. Medium chain triglyceride oil supplementation is done in all patients. Young child will not be able to say it, but if there is a older child and you find that there are nighttime crying episodes, there can be pruritus in the child. Older child obviously will be able to tell, because we are talking about the overall general management of neonatal cholestasis. So in pruritus, ursodeoxycholic acid is found to be the most effective therapy. If that is not available, you can consider rifampicin also, and you can try cholestyramine as well. But they are reserved for refractory cases. And you need to do the management of the underlying cause, which has caused neonatal cholestasis. Finally, vitamin K injections need to be given in all of these patients. Now coming to the specific management of biliary atresia. Whenever you have made the diagnosis, all patients, they need to undergo exploratory laparotomy. So open surgery is done. During that surgery, you perform peroperative cholangiogram. So cholangiogram has to be done, and see the extent of the disease and whether the lesion is correctable or not. When you do cholangiogram, you will find two types of outcomes during the surgery itself. Either it will be a correctable lesion which can be surgically corrected, but it is seen in minority of patients, or there will be no correctable lesion. We are talking about the definite management for biliary atresia here. If it is a correctable lesion, you will do the definite surgery, that is, you will establish direct biliary drainage and the patient will be fine. But this is not always the case. Many times what you find is there is no correctable lesion which is present. And so in these patients, you need to perform a procedure known as Kasai's operation. Kasai's operation is also called as Kasai's hepatoportoenterostomy. The success rate of Kasai's surgery is better if it is done before 8 weeks of age. According to Nelson, it is successful if it is done before 8 weeks, that is 2 months of age. If you do it after 8 weeks, it may not be possible for the benefit of this surgery to be available. So this can be a potential MCQ, by what time Kasai surgery should be done. If the patient presents late or fails, the final therapy in all these patients is liver transplant. Liver transplantation is the last resort for these patients. And remember, MCQ point asked multiple times in the past, extrahepatic biliary atresia is the most common indication for liver transplant in children. So in bracket you can write that EHBA is most common indication for pediatric liver transplant? MCQ point. So this finishes the discussion of biliary atresia. In the end, some MCQ pearls can be asked in the exam. How would you distinguish between extrahepatic biliary atresia and neonatal hepatitis? Remember that EHBA is usually not familial. It does not show a positive family history, whereas neonatal hepatitis may be familial in a significant number of cases. Second thing, in EHBA, there is late hepatosplenomegaly. HSM means hepatosplenomegaly, whereas in neonatal hepatitis, there is early hepatosplenomegaly. Third thing, in EHBA, there are associated malformations in 30% of cases. In neonatal hepatitis, there are no malformations. When you do liver biopsy, EHBA, along with other features, the hepatic architecture is intact. Whereas here, the hepatic lobular architecture is disrupted. There will be other features like inflammation, necrosis, etc. happening that I am not mentioning. Plus, there will be presence of giant cells in idiopathic neonatal hepatitis. And finally, EHBA, the AST and ALT levels are only mildly elevated. Whereas neonatal hepatitis, they may even be normal in EHBA. Whereas in hepatitis, obviously AST and ALT will be significantly elevated. So these are some of the points which can be asked regarding how would you distinguish between EHBA versus neonatal hepatitis, and these points will give you the clue. So this finishes our discussion of the neonatal cholestasis. Some of the related conditions which can cause neonatal cholestasis have been discussed separately in the hepatology module, which includes the Ehlers-Danlos syndrome and a few words regarding PFIC.